So really what I want to talk about this morning is a little bit about the curriculum, and as Rob said, we've got a new one coming. So this is the 2010 curriculum. It's been revised a couple of times. Last revision was in 2015, and the 2021 is being created as we speak. The drivers for this really have been, first of all, the Shape of Training report, which really recognised that training as we had it is pretty rigid, it's pretty slow to adapt to the changing environment, all those things that Ravi's been talking about. It's been very fixated on time. Those of you who are trainees in the audience will recognise that, we're nitpicking over, have you done X amount of weeks in ITU, have you done this, have you done that? It's ridiculous really. We should just be able to say that, if you can show that you can do it, then that's fine. It doesn't matter if you've done 12 or 13 weeks doing something. And it is a bit of a tick box exercise, isn't it? All those assessments that you end up sending out, and as consultants we end up filling in. Sometimes it feels a little bit, not pointless exactly, but, are we assessing the right kind of things? It was recognised really that there's quite a few barriers to changing specialties, and surely we should be able to take some competencies that we've got from one thing into another specialty if we choose to move. Lots of medical specialties have their own particular requirements, and are all those absolutely necessary for each one? Lots of things are cross-curricular, and so we need to sort of develop that a little bit more. It was also recognised that the workforce is changing, and we need to look at ways of working to facilitate everybody's lives. Less than full-time working is essential, I think, for a lot of people to maintain their engagement with the profession. And also different ways of working, things like getting GPs to come and work in hospitals, all that sort of thing. So not the rigid kind of structure that we've had in the past. And as Ravi's outlined very clearly, there's a clear need to adapt to the changing needs, both of the patients and what the health service needs at the moment. So it all kind of came from this first document. Sorry, it's not projected very well, it's all a bit blurry, but this first thing, Promoting Excellence, which came out in 2016, and it's looking at the training environment and the standards that local education providers, so the trusts, have to adhere to in terms of educating both undergraduate and postgraduate trainees. And there's some themes about the environment, the culture, governance, leadership, all of those things. So that was the first kind of thing that came in. And then following on from this, we've got Excellence by Design from the GMC, and this is the real thing that has this thing that's driving the curriculum change. And the big thing for this is that curriculum for all medical specialties, so not just us, but for medicine, surgery, everybody, they all have to be revised by 2020, and that's not very far away. So the college have got to submit at least their first draft by December 2020, and then that will obviously be modified. And it's going to look totally different to the way things are at the moment. So we're very familiar with what we've got with all the annexes A, B, C, D, E to G, core, intermediate, higher training, all those things. We're going to be less focused on have you done a day case module, have you done a GUG module, that sort of thing. And you're going to have to show specialty learning outcomes, some of which I'll show you a bit later on. They've said that all curricula have to demonstrate general professional capabilities, and again a bit more about that in a minute. These specialty learning outcomes, there must be stakeholder involvement, so all these people, all of you, everybody needs to be able to input into what this curriculum should be like. There should be a reduced assessment burden, which I'm sure for those of you who are trainees would very much welcome, because there are so many that you have to do, aren't there, for every single little module, and you feel like you're repeating yourself over and over again. And the curriculum really ought to be flexible and transferable, as we've said. So lots of good ideas about all of this, but the actual implementation of it, I think, is going to be a bit more challenging than perhaps they're appreciating when they first write these things. So these are the general professional capabilities that they want everybody to have, and it's all kind of, things that we would expect from a good doctor. So professional knowledge, professional skills, values and behaviours. And then in amongst all that, leadership, team working, safeguarding, all of those things. So these things that everybody's got to demonstrate and demonstrate throughout their training. And these generic learning outcomes, which are mixed in with these kind of 15 to 20 things that they want people to show. So they need us to show that we can demonstrate values and behaviours, improve quality and safety of anaesthetic practice, identify vulnerable people, undertake managerial roles. So all that sort of thing. So you'll perhaps recognise this from what used to be in Annex A, which is the sort of general professional stuff, and Annex G, which is the management and teaching type stuff for those of you who are in training at the moment. And then on from that, there's going to be some specific learning outcomes. I went to a meeting at the college last couple of weeks ago, and they had some of these there. We weren't allowed to take any of them away, but I did take a sneaky photograph of some of the slides. So basically, it's all about, big umbrella terms. So can trainees demonstrate that they can manage pain? And there's going to be a kind of stage 1 thing for that, stage 2 thing, stage 3 thing. But overall, can you do that as a specific learning outcome rather than multiple DOPSs and KEXs and all that sort of thing? Can you manage critical illness? And you might be able to evidence that from time spent on ITU, time spent in A&E, that sort of thing. So, bringing all your kind of experiential stuff in. Providing safe and effective general anaesthesia, that's a fairly big specific learning outcome, I think. But they're breaking that down very much into some subsections, but still, not as detailed as can you do a DOPS for a intubation, that sort of thing. It's like the whole package. Can you manage this sort of whole case? Can you provide safe and effective regional anaesthesia? And bringing in all sorts of things into that, so that you can say, this is my learning outcome. Yes, I can do this. So I think this is quite aspirational, and there's a really short time frame for all of this. But the GMC say that it's got to be done, so we're going to have to get on board with all of this. So some things we also need to think about when developing the curriculum is obviously welfare and morale of trainees, which isn't brilliant at the moment, we all recognise. Working patterns aren't great, assessment burden isn't great. A lot of people are finding difficulties with resilience, with burnout, all those things, and people are being surveyed multiple times, and the incidence of all of this is getting higher and higher and higher. So whatever we do with the curriculum, whatever the college do with the curriculum, it needs to address welfare and morale of our trainees to stop them getting sick and to stop them leaving. And also for consultant staff as well, because this doesn't sort of stop. It carries on the whole way through. It needs to address what the needs of the service are as well, and can we deliver all of this as well as maintain a good service. It needs to make sure that we don't have any patient safety issues are minimised or guarded against as a result of inadequate training. So training programmes need to have some quality assurance around them so that we make sure that we can deliver the right sort of things with the right outcomes for the patients. And also we need to coordinate with all the other curricula that are going on, and particularly for us with THICM, with ICM, because the marrying up of the dual trainees curricula is very, very difficult sometimes, so we can't have one not talking to the other one. So what the college have done, they've kind of got groups of people together to say what they think about what the curriculum should look like and what the structure of training should look like. And this is what people are kind of thinking at the moment, and this is the route they're wanting to go down. So the general feeling is to maintain core and ACCS training routes. That's seen as a kind of valuable thing. So you'll have some people coming in through ACCS, which is a good programme, I think, and other people that don't want to do that, they just want to be anaesthetists, and that's fine. General feeling is that run-through training is unpopular, so there needs to be a break at the end of core and then a reapplication for a specialty number. The feeling that core training would perhaps be better delivered over 3 years rather than 2. And actually, most of our core, or a lot of our core trainees are taking an extra year before they go into specialty training anyway, so it's just formalising that. A lot of the issues from that are delays in passing the primary. So if that's kind of taken into the training programme, then that seemed to be a better thing. The suggestion that intermediate training should last until ST5, and that should incorporate the final FRCA. We've moved to that currently because people can now go into ST5, into the first 6 months of ST5 without their exam, without needing any extension time, but again, formalising that a little bit more. Higher and advanced training should be only taking 2 years. That assessments should be less frequent, but more meaningful. So pretty much, more whole practice assessments rather than just, can you, put an arterial line in or something. And then this thing about entrustable professional activities, which I understand is almost like, it's like the ALMAT type thing. Can I leave you to do all this stuff by yourself? Am I happy with you doing this? Can I go to the coffee room? Can I be happy that you're going to be able to do this list by yourself? So that's the direction that all the kind of stakeholder people that are interested are pushing it in. There's another stakeholder meeting tomorrow at the college. I don't know if any of you are going. I think Miles is going. Others may be going down. But, if you see this sort of stuff advertised, then do go, because they are really at a very early stage of all this, and it's very fluid. So any input that you want to give, please do. And then in terms of the outcomes, they don't necessarily need to be specialty related. So you can have, a merging of day case, general, regional, whatever. You can, bring experience from all of those things to get your outcome done. But there will obviously be some exceptions in terms of specific things like obstetrics, peds, pain, ICM, where there may be some very definite things. Can you manage stereodetection properly, that sort of thing. Everybody's very keen that a breadth of practice should be maintained, and again, from the shape of training thing, it's all about people having a good general ability and general scope of practice. They don't want people doing too much ICM, apart from if you're a dual trainee, so 9 months maximum, that's it. That's all we do in this school anyway. I think other schools suffer a little bit more in that trainees keep being put into ITU a lot. So that will change for a lot of schools. We're okay with that. Some business about credentialing. I don't know if any of you have heard about this before, but there's the options potentially of doing post-CCT credentials in things like pre-hospital medicine, pain, sleep medicine, and potentially ICM for those who aren't dual trainees. Or also getting people from other specialties. So, for example, GPs could have a credential in pain to allow them to practice in pain clinics, that sort of thing. So again, bringing other specialties in and not us working in a silo by ourselves. And then wanting to maintain out-of-programme options to increase or to maintain flexibility to trainees when they want to go off and do other things, which I think, personally, is massively valuable. We put everybody on a conveyor belt and they all start at one end and they all drop off at the other end. And I really like being able to send people off on OOPS to get, a bit of value-added stuff, and hopefully they will be able to bring those things back. So that's what it's going to look like. So you're going to have stage 1, so that's going to be CT 1 to 3. You're going to get your initial assessment of competence and initial assessment of OBS competence and the primary. You do 6 months ICM in that bit rather than 3 that we normally do at the moment. And you'll look at getting some core outcomes and a few of the general intermediate outcomes in that. So you'll have stage 1, that's equivalent to current core training, and then that's that. You then have stage 2, which is ST4 and 5, which is going to be uncoupled, so you have to apply for that job. Should last for 2 years. You should be getting the final. You'll only have to do a single block of neuro and cardiac, which I know the route makers will cheer about, because particularly at Queen's, and I'm sure it's the same here for cardiac, it's really tight. So the need to do this whole spiral thing, if you've got to do it once and then you've got to come around and do it all again, is probably going to go. And then you'll work towards the intermediate and higher level outcomes. And then stage 3 is going to be ST6 and 7, so the duration of the whole training programme is going to stay exactly the same. So this will be a couple of years, a year to look at developing general consultant skills, and then a year to look at special interest type areas. So that's what we're looking at. So some of the opportunities with this, well, hopefully it may act on some of the morale issues, burnout issues, welfare issues associated with things like timing of the exam, extreme pressure in terms of having to get everything done very quickly, and the burden of assessments. So that it may improve those things. It might address some of the inconsistencies in higher and advanced training. We'll see. It may increase trainee retention, and actually that's what we want, because we haven't got enough trainees coming through and we have a shortage in the workforce. It will let us review how we do the assessments, and I think that's really important, because I don't think they work at the moment. And also we can meet some of the recommendations of the exams reviews as well. So there will be some good things. There'll be some challenges. Expectations of the GMC are going to have to be fulfilled. We can submit stuff to them. They can say, no, that's not good enough. Want something done very differently. So we're going to have to negotiate that. Expectations of the profession. People may not like this. They may not want to do this. And also of perhaps some of the specialist societies, who are going to see people coming through who haven't had the same specialist training that perhaps people have in the past. We're going to think about how difficult it's going to be to do the different structures of this thing, and what posts are going to have to look like in hospitals, and a different formation. So is it going to be a 3-2-2 or is it going to be 2-2-2-1? So also delivery of your special interest areas, how exactly is that going to happen? And how is this all going to work with those curricula that run alongside us? So is it going to work with ICM? Is it going to work with ACCS? And is it going to work with FEM? Lifelong learning, Lena's going to talk about in a little bit, but obviously it's set up at the moment to do core, intermediate and higher, so that's all going to have to change. And communication, as ever, is going to be difficult, and everybody's going to have to be on board with all of this and understand what we need to do. So that's the curriculum. It's very much a work in progress. College very much wants input from everybody into all of this, and we're just going to have to keep our eyes out for what we're going to need to do with all of it. Just a couple of other bits, really. Other developments are the college wants a standard ARCP checklist. We have some checklists within the school, not all schools do, and they recognise that outcomes are very different depending on where you train, so they're wanting us to have a fixed college-approved ARCP checklist. So I don't think it's going to look very different to the one that we've got at the moment from what I've seen, but we need to be looking out for that. So those of you who are educational supervisors need to know what's in that, and obviously as trainees you do too, so you know where the goalposts are. Producing evidence for annexes A and G. Really, it's not much of an update, but just to say that there needs to be evidence at each ARCP that you are engaging with that. So Annex A is obviously the professional capability stuff, and G is the teaching, research, management thing, so that needs to be clearly evidenced. And they've produced a position on reflective practice. Basically, there is no set number of reflections and things that are needed for any modules, and module supervisors aren't to ask for specific things like that. but there does need to be evidence of reflection if there's been any incidents and things, and that needs to have been discussed properly. Any questions from any of that?